Hello, this is Dr. Bhomik. I'm a pediatric endocrinologist and professor of pediatrics, University of South Alabama, and at present retired. I was also in U.S. Air Force for 20 years and retired colonel. And today I'm going to present congenital adrenal hyperplasia. But I just want to emphasize that this lecture or talk has been made for medical student in their senior year, pediatric resident, and those who will be taking the pediatric board. And this is also applicable for the pediatric nurse practitioner as well. This is a humongous lecture, but I am just going to give what a pediatric resident and medical student ought to know to pass their USMLE or pediatric board examination. So this is by far is not a complete lecture. Before we go and discuss anything about congenital adrenal hyperplasia, we need to understand some of the basic function of the adrenal cortex. So there are three hormones that secretes from adrenal cortex, and they are responsible for retention of sugar, salt, sugar metabolism, and sex steroid. So let's look at that. The outer layer is zona glomerulosa, and that's the one produce mineralocorticoid, which we call salt retaining hormone. Middle layer is zona fasciculata, and this layer is primarily responsible for production of glucocorticoid, which is the sugar metabolism hormone, as the people say. Then the inner layer, mostly zona reticularis, produce a sex hormone. So I know that how much you love to see this one, and so this is the steroid biosynthetic pathway. I'm not going to go through that, just going to show you that the basic hormone is the cortisol. And as you remember, the 50% of the cortisol comes from inside in our body is produced, and other about 50% from our food. But so we need cholesterol to synthesize all the steroid hormone and the sex hormone. So therefore, this is a mineralocorticoid or salt pathway, and as you can see, it's come from the cholesterol and come way down by different enzymes, and that we'll be talking the appropriate enzyme that will be requiring to understand the disease process. So here is 3 beta, then 21 hydroxylase, 11 hydroxylase, and so forth, cortisol pathway, and this is the sex hormone pathway. We'll have a better diagram as I proceed. So control of the adrenal function is mineralocorticoid is primarily controlled by the renin angiotensin system. So in order to estimate the function of the mineralocorticoid part of the adrenal gland, you got to assess plasma renin activity. But ACTs play a minor role. It is the PRA, plasma renin activity. Glucocorticoid and sex hormone, they are controlled by ACTAs. So congenital adrenal hyperplasia is inherited enzyme defect of the steroid biosynthetic pathway, and many or several enzymes are involved, and as a result, depending upon what enzymes are involved, the body produces inadequate cortisol, aldosterone, but they produce also that excess amount of androgen in common types that we will be talking. Increased ACTH also make adrenal gland bigger, so we call hyperplasia of the adrenal gland. And this enzyme defect, they are autosomal recessive. They are autosomal recessive. So most common enzyme defect that you will see is a 21 hydroxylase and then the 11 beta hydroxylase, 3 beta hydroxysteroid dehydrogenase, 17 hydroxylase, 1720 desmolase, 2022 desmolase, and 18 hydroxylase. And these enzymes are there, and they are very, very rarely involved. So we are talking mostly, the one I underline is 21 hydroxylase deficiency and 11 hydroxylase deficiency and some 3 beta hydroxysteroid dehydrogenase. So if I go to the biosynthetic pathway, I will be able to explain better. And we also know that 21 hydroxylase deficiency is more than 90 percentile, close to 95% of all congenital adrenal hyperplasia, and more than 50% are salt loser. And as a result of this, there is a virilization of female infant at birth in severe cases, but with simple cases or inadequate enzyme block may not give or classical features. And the male newborn, the point to note, the male newborn with 21 hydroxylase deficiency would have no changes of their external genitalia. So they will be just like a normal male. And as I said, is transmitted as autosomal recessive. This diagram I found is the best one in my judgment. As you can see, it all come from cholesterol. But see, this pathway, this up to this, is present both in adrenal gland as well as ovary or testicle. So this pathway is very common. This is the same pathway that we see up to this line, and here is the gonads, ovary or testicle. But here this part is also, from here this part also come down to the adrenal gland. So let's look at the 21 hydroxylase deficiency. Block is right here. Therefore, you would expect the significant concentration of 17 hydroxyprogesterone, and it goes laterally since there is no block there, and they produce lots of sex hormone testosterone, and the DHEA, and so it goes this way and is blocked this way. So there is not enough cortisol synthesis and not enough aldosterone synthesis. So that clearly make it easy for you to understand that this absence of aldosterone and cortisol make you hypoglycemic and salt loser. Okay. And glucose metabolism is also defective. So this is autosomal recessive, and this is the gene located in HLS system, chromosome number 6, and it's class 3 antigen. Right here is the class 3, and here if you magnify this one, this certainly will not be in your test they own, but you can see that the 21A, which is right here, is the gene defect. And by looking at this gene, we can do the amniosynthesis and we can tell if the baby is affected or not. So this has a significant impact in identifying the babies or the pregnancy of a mother who has another baby with CAs and to identify them. And so that test more or less now taken over than hormone test. This is a baby that was born, and I took care of this baby and I was consulted. And so you can see that this is a labio-scrotal fold, but this is the labia. It is obviously a little edematous, and this is clitoris and this is urethra. And this is clitoris. The next one will be even better, and if you can measure it, it's almost an inches, and which is normally 0.5 less than 0.5 centimeter. So this is clitorid enlargement of clitoris, and this is the typical ambiguous genitalia you can see in the newborn period when the baby was born. So 21 hydroxylase deficiency has got a very various way of presenting. The one that I show you, that a very classical CAAs, 21 hydroxylase deficiency, and is going to be a salt loser. When they have that much ambiguity of the genitalia, they are going to be salt loser, and they are the classical one, salt loser. But there is a simple virilizing form, which is a non-salt loser, but sometime in a very stressful situation, those non-salt loser also may lose some salt. And late onset type is actually more common, is about 1 in 200, and 21 hydroxylase deficiency is 1 in 10 to 20,000. I have a formula that I remember. This type 1 diabetes is 1 in 400, congenital hypothyroidism is 1 in 4,000, congenital adrenal hyperplasia is 1 in 14,000. This is just to remember. That's not exactly written in the stone, but you can actually come very close. And then here is a heterozygous carrier, and they are absolutely asymptomatic, and by doing an appropriate test, they can be identified, but they don't need any treatment. So when we are trying to diagnose this condition, 21 hydroxylase deficiency, 17 hydroxyprogesterone is going to be markedly elevated. So is the progesterone androstenedione. DHEAS testosterone is also going to be elevated. If you do the urine excretion of pregnancy trial and 17 ketosteroids, they are elevated. Serum ACTs level is high, and plasma renin activity is also elevated in classical salt loser type. Electrolyte and water disturbances is important. Salt losing varieties is very dangerous and may present with Addisonian crisis, and Addisonian crisis is characterized by hypovolemia, low blood pressure, low blood sugar, hyponatremia and hyperkalemia. This is the hallmark of Addisonian crisis or adrenal crisis. Low sodium, high potassium. If you see sodium level is low and the potassium level is low, that's not your CAAs or adrenal gland problem. So this electrolyte, sodium and the potassium, is very important to see which direction they are going. In classical form, there will be hyponatremia because they lose sodium, and there is hyperkalemia, acidosis. And one thing to remember, that this electrolyte abnormality may not be evident in 1, 2, or 3 days. It might take a week before this pattern is actually revealed. And so that gives us plenty of time to do all the investigation that we would like to do. thanks to the neonatal screening program, now we can detect those male babies who are born with congenital adrenal hyperplasia and they do not have any ambiguity. And so those are the one who was in a very significant danger because they probably will present with a vomiting uh, adrenal crisis which may look like that they have been suffering from sepsis or congenital hypertrophic pyloric stenosis, and, and that has been confused many a times. But thanks to the screening program, now we can, within a week or 10 days, we can get those babies identified. But and that helps because sometimes the presentation of fluid electrolyte that I mentioned may not come within a week or so. Treatment wise, I'm just going to get outline. Since this is the deficiency of glucocorticoid, we have to give the corticosteroid, which is in the form of hydrocortisone, and mineralocorticoid also has to be replaced, and which comes in the form of what you call Florinef, and it is best managed by the pediatric endocrinologist. But I have to emphasize that in newborn period, when they born with these ambiguous genitalia, how to give this information to the parents is an art than a science. And various endocrinologists has done differently, and your physician may do differently. Then that's what I'm not going to elaborate how I do. However, this is a multi-specialty approach. Neonatology, endocrinology, pediatric urologist, and genetics specialist are involved. And as they will need the sonogram and karyotype and the blood test. So this is best managed by specialty team. And there will be something that adrenal crisis, stressful situation, and the factor that make the patient vulnerable for adrenal crisis will be discussed a little bit later, but I will present this one in a complete form in another form of lecture. Another lecture that I am going to give is the how to withdraw the patient from chronic long-term use of steroid, and there I will explain and give you more details. 11 hydroxylase deficiency is about 5% or 3 to 5%, and 3 beta hydroxysteroid dehydrogenase is about 1% or so. So there is a decreased secretion of the cortisol, aldosterone in the production of compound S, which is called DOG, and for the purpose of your examination, this is very, very important. These varieties, they have similar ambiguity like 21 hydroxylase, but for the purpose of your exam, if there is a case, read carefully, look at the blood pressure. If you see the hypertension associated with the presentation in your exam, then you think 11 hydroxylase deficiency. There is another one we'll call 17, but they are so rare for the purpose of your exam. Remember, 11 hydroxylase deficiency is associated with hypertension. And again, 17 hydroxyprogesterone is elevated, but you will see androgen, everything is pretty much like 21 hydroxylase, but this diagram is going to show you the block is here. So what we also see, besides 17-hydroxyprogesterone, we have significant elevation of compound S or 11-desoxycortisol. And here is the increase of desoxycorticosterone, which is a weak mineralocorticoid. So therefore, they have plenty of testosterone, then they have delta 4 androstenedione. These are all androgen. So there will be ambiguous genitalia. And many of them are late onset, but they may have been milder form, but as they grow older, and that's the time they manifest, and they present with the enlargement of phallus, increased growth spurt, and in female enlargement of the clitoris, and the common finding will be hypertension. The one thing, although this is not exactly the part of this discussion, but I'm going to emphasize, is that in central precocious puberty, you exactly see the same thing: increased growth spurt, advanced bone age, enlargement of the phallus, and breast development. But in male, the testicular size will be large and it will be appropriate for the development of pubertal stage. But in congenital adrenal hyperplasia, the testicle will be small. So it is a peripheral sexual precocity. So the testes will be small, but the phallus and the growth spurt, they are going to be there. So since desoxycorticosteroid mineralocorticoid, so they usually don't, even then they don't have enough aldosterone. Enough of this can prevent a short losing crisis. And desoxycortisol, which is a compound, this one will act as a cortisol. So this patient usually don't present with crisis, because in this situation the body can use desoxycortisol, can be used as cortisol, and mineralocorticoid activities will be provided by this. So acute adrenal crisis, just a few things that I like to mention is that truly medical emergency, and they die if the proper care is not taken. The sign symptoms include dehydration, vomiting, diarrhea, fever, tachycardia, lethargic, and they develop shock state. And if you look at the laboratory finding, there will be hyponatremia, hyperkalemia, low blood sugar, and metabolic acidosis. The key of the management of this is the volume expansion. It is normal saline is given regardless of the age, and usually you can give like a 20 ml per kg within an hour, and then depending upon the situation you can repeat. Then keep an eye on the blood sugar, because as soon as the blood sugar is low or you find the sugar is low, you have to supplement your fluid with glucose. The very important is to give IV solucotif or hydrocortisone sodium succinate 50 to 100 milligram per meter square, and this is a rough guideline, but your doctor, your endocrinologist or specialist might do it a little bit differently. And this dose in the beginning will give you enough coverage for mineralocorticoid activities. The one thing that important to remember, that if IV is not available or it is not possible, the hydrocortisone can be given IM, the same dose. And actually we teach the family when they go home how to give the injection and how much, and they go home with a portable or injectable hydrocortisone. And once this crisis has happened, actually should not happen, the reason of the crisis should be explained to the family, because this could be very dangerous. Now the last slide, they used to call the what's the most common cause of disorder of female sex differentiation, or in other words masculinization of genetic female. And the most common cause is congenital adrenal hyperplasia due to 21 hydroxylase deficiency. Less common is the 11 beta hydroxylase and 3 beta hydroxysteroid dehydrogenase deficiency. And they are female, their karyotype is 46XX. In the older days they used to call female pseudo-hermaphroditism, and that term is not used anymore or not should be used. And so most common cause of masculinization of a genetic female is 21 hydroxylase deficiency. Thank you.